Behc disease. Behc is somehow classified as a rare disease, although it's not rare in certain populations. In Italy, it is maybe rare in people from the far north, but it's quite common in people from the center, from Sardinia, or from the south of Italy. It's an old disease with a history. It was first described in 1937 by Hulusi Behc, a professor of dermatology at the University of Istanbul, who recognized the association of recurrent aphthous oral and genital aphthous, recurrent aphthous oral and genital, and iridocyclitis hypopion. However, we have evidences that this has been described earlier. Prevalence of the disease is very variable, and you can see it in the following map. It's rare in the US, in Italy is quite frequent, and extremely frequent in Turkey. Symptoms of Behcet disease are recurrent oral aphthous, 98-99% of cases, ulcers in the oral mucosa that are extremely painful and may be of different dimensions, genital aphthous 79%, skin lesions 62%, uveitis 53%, arthritis 35%, neuroblastoma 22%, vascular changes 2.5%. Some of them are quite characteristic. And it may be difficult to diagnose a patient if he doesn't show those symptoms. Okay, you can see here some aphthous. This kid has ocular involvement with signs of inflammation, pain, and bilateral hypopion, which is the collection of pus that you can see in the bottom part of the iris. There is hypopion, that means anterior uveitis. In Behcet, we have systemic perivasculitis. If you biopsy vessels, you don't see damage to the vessel wall like in vasculitis, but there is inflammation around the vessel. So there is early PMN infiltration and swelling that will bring about fibrinoid necrosis. Moreover, you will have neutrophilic and mononuclear cell infiltration starting from around the vessel and going toward the skin, which will lead to necrosis of the dermo-hypodermic junction and thus to formation of aphthous and ulcers. There is inflammation, so there are signs of generalized inflammation, that is increased circulating pro-inflammatory cytokines, TNF, IL-1 beta, IL-8. Many factors have been hypothesized to be connected to Behcet disease. Environmental factors, infectious agents, maybe Streptococcus sanguinis, because of its high homology of bacterial antigens, which is SP60-65 kilodaltons, which may be able to trigger the action of gamma delta T lymphocytes, which are kind of crossroad between immune and adaptive immunity. Hypersensitivity to HSV1 could be involved, hyperreactivity of PM polymorphonuclear leukocytes, HLA-B251 related, genetic predisposition, association with HLA-B 5101 and B5108, especially in Mediterranean area and Japan. The geographic distribution of HLA-B51 in the population corresponds to that of the disease. You can also have a linkage disequilibrium to other allelic variants of the MHC region. As I told you, gamma delta T cells recognize an antigen. They become activated and start producing factor, start recruiting polymorphonuclear cells. There's leukocyte extravasation and inflammatory damage. Consider that there are a number of factors that have been associated, but none of them is enough to cause the disease, and none of them is absolutely required. Like you see HLA-B51 alleles, male sex, ICAM1 alleles, streptococcal antigen, molecular mimicry, factor V lead and mutation. Going back to our patient with Behcet disease, you can see that it is definitely a systemic disorder. It can cause ocular disease, vascular disease, ischemic heart disease, cardiac or pulmonary or peripheral vessels aneurysms, aphthous ulcers involving the entire GI tract, genitourinary lesions, ulcers or arthritis, epididymitis, skin lesions, folliculitis, erythema nodosum, arthritis, and deep venous thrombosis. If I tell you all the symptoms, is there anything that comes to your mind? Crohn's disease. Indeed, Crohn's disease has huge similarities with this pathology. Consider that there may be a consistent overlap, at least in some forms, between these two disorders. This is again the general prevalence of the conditions that these patients experience. Pathergy test is a phenomenon which describes a pathological response to stimulus. Typically, patients with Behcet disease have a significant response to an anoxious stimulus, like the scraping of the puncture of the skin with a completely sterile needle. During normal blood withdrawal, these patients will develop a reaction at the site of puncture, typically a pustule, which is the expression of the eugenic immune system hyperactivity to this stimuli. During pathergy test, we scratch the skin with a sterile needle after disinfecting the area, and in patients with Behcet, you will have a strong inflammatory reaction. So you see here the mucosal and skin manifestations. You have oral afte, minor, major, and herpes-like, 97-98%. Genital afte, scrotal labia minora and majora, 79%. In the skin we have pseudo folliculitis and papulonodal acne-like lesions, 62%, dermohypodermic nodules, 23%, erythema nodosum-like, superficial phlebitis, 2%. Pathergy test is positive in 49% of cases. Erythema nodosum you see here, and ulcers with necrosis. A significantly involved organ by Behcet disease is the eye, uveitis being the most common manifestation, both anterior and posterior. Posterior uveitis is quite often asymptomatic, and you will see just intravitreal infiltrations when you examine the eye of the patient. Consider that roughly half of the patients have retinic vasculitis, so this is a disease that may severely involve the eye. If the patient has eye disturbances, you should tell him to refer to an ophthalmologist because clearly, if you have a significant retinic vasculitis, you may have problems that may condition the capacity of the patient to see well. So the diagnosis and the treatment are warranted. For diagnosing Behcet disease, the patient should have recurrent oral ulcerations, which is necessary for making the diagnosis of Behcet disease, plus two of the following: recurrent genital ulceration, eye lesions, anterior-posterior uveitis or cells in vitro or retinal vasculitis, skin lesions, erythema nodosum, pseudofolliculitis, papulopustular lesions or acneiform nodules, and positive pathergy test. Pseudofolliculitis is another typical manifestation of Behcet. It is called pseudofolliculitis because it is a completely sterile inflammation of the hair follicle, just microtraumatic, and it results from the ingrowth of body hairs under the skin. It generates a local inflammatory response. There are a number of less common manifestations of Behcet, like narrow Behcet, 22% of cases, and vascular changes, 2.5%. The typical manifestation of vascular inflammation is venous thrombosis, with the classical deep venous thrombosis and of the lower limbs and in other particular sites. For instance, Budd-Chiari syndrome. In Behcet thrombosis of suprahepatic veins, you define Budd-Chiari syndrome, and the obstruction of the outflow of blood from the liver up to the right atrium is common. Strangely enough, the same may happen in inflammatory bowel diseases. So venous thrombosis, arterial, where we have Budd-Chiari syndrome, arterial thrombosis, which is rare, and arterial aneurysms, which are rare. There is a significant involvement by narrow Behcet. One of the most common findings is headache. Most of them are tension or migraine type, but 10% are secondary to a direct CNS involvement. One of the most typical manifestations, and on the other side one of the most worrisome manifestations because it's not only problematic but is also difficult to treat, is cerebral venous thrombosis. Roughly 20% Patients with neurological involvement will develop it. It should be treated because it causes intracranial hypertension and all the damage that may derive. So, neuropathology is subacute meningoencephalitis with massive infiltration of inflammatory cells, PMN, lymphocytes, macrophages, and areas of necrosis and apoptosis of neuronal cells. You have intense inflammatory infiltrate of small vessels, both arterial and venous. No real signs of vasculitis, not infiltration or fibrinoid necrosis of the vessel wall, but inflammatory perivasculitis. Axonal loss and gliosis and atrophy of the cerebral peduncle in advanced stages, and elevated levels of inflammatory cytokines IL-6. Classification of neuro-Behc can be parenchymal in the brainstem or non-parenchymal, such as central venous thrombosis, intracranial hypertension, or aneurysms. Headache is the most common neurological symptom in Behc. In 70% of cases is migraine or tension type. In about 10% of cases is secondary to direct CNS involvement. Non-parenchymal neuro-Behc can be cerebral venous thrombosis, there can be involvement also of the peripheral nervous system. Then we may have also other manifestations like articular manifestations such as arthritis, GI manifestations such as ulcers, and orchiepididimitis. So we have articular, 25% of cases, spondyloarthritis, enthesitis sacroiliitis, oligoarthritis, knee, ankle, wrist, elbows, and GI that are rare, and orchiepididimitis 30%. So we have a significant overlap with IBD, especially Crohn's, and in some cases the diagnosis may be poorly distinguishable. Like we have also involvement can be also overlap with uveomeningitis, arteritis, connective tissue diseases, and spondyloarthropathies.